How you doing today? My name is Bob Kraft. I am a paramedic instructor with Sarasota County Technical Institute. I've been a paramedic for 13 years. I am the lead paramedic instructor for class 913B. There are 8 people in attendance, and we're going to get started. Today we're going to be discussing the application of plethysmography in EMS. Plethysmography is a Greek term applied to the measurement of volume and volume displacement. That's nice. It doesn't really mean anything to us, all right? What it does mean is what I'm going to talk about. And for the rest of this lecture, we're going to talk about plethysmography, and I'm going to use the term pleth. And this is really what we're asking. What can it do for me? How can pleth help the everyday EMS provider in the administration of high-quality patient care? I'm going to show you, and I'm going to show you how you can apply it in the field and use it as a measurement quantitatively for your patients. How do you know if a pulse ox is correct? When you put it on, it gives you a number. How can you determine that the number you're seeing has value and that it is real? That's what we're going to talk about today, and I'm going to expand upon it. This is how you determine it. The waveform. If you look right here, there's a waveform, and this is actually associated with the percentile or the pulse ox for your patient. So when you put the device on and you attach it, there's a waveform attached. The interesting part about it is that the waveform is directly associated with contraction of the left ventricle of the heart. As the heart contracts, pressures move through the aorta and then down to whatever device you are actually analyzing or it's assessing based on where you put it. So notice that there's a slight delay. As you move farther away from the heart, the delay will become greater. As you get closer to the heart, the delay will become shorter. It'll also slightly change the waveform itself. This waveform is true pressure. It is the movement of fluid through the capillary bed from which you are monitoring. There are some complications, though. There are reasons that the waveform does not exist or does not show. We're going to talk about them. No waveform medical complications. Low circulation. If you put it on the finger of a patient and the patient's not circulating well or they have low volume, you're not going to get that waveform. You might get a percentage, you might get a number, and that number might be completely off from what you actually get or what the actual percentage of pulse oximetry is. Also hypothermia, because of shunting in the blood and constriction, you will get low flow in the periphery. Hypovolemia, again, low flow. Or unknown causes. The device wants to show a false reading. We don't know why. You can see it sitting on the table and the thing will say 90% and it's not even hooked up to anybody. I don't know where those readings come from and there's no analysis on any of that. There's also the condition of a good waveform with a false O2 saturation. There are 2 specific things that come into mind when we talk about this. Carboxyhemoglobin, or CO poisoning. Carbon monoxide poisoning. Carbon monoxide absorbs the hemoglobin 200 times greater than oxygen. So if you have a patient that's been exposed, their pulse ox may say 100%. And they're actually hypoxic. They're actually starving for oxygen due to that. Okay? High flow O2 is the treatment for it. Also methemoglobin. Methemoglobin is an iron deficiency or an absorption of a different type of iron than what we can actually process. The only time you'll actually see it or see the results of it is you might start an IV on a patient and you might catch brown blood inside the flash chamber. It's possible. Applications. We're going to talk about some applications. First question, is my O2 sat correct? When you bring up your monitor and it says 2,3 AVF and you see a pulse ox of 99 and the patient's blue or hypoxic, you can switch it to the pleth wave and see if that wave's actually correct. See if there's a wave there. If there is, then that wave is right. Maybe there's something else going on. What if it's wrong? What if it's a straight line? That means that the pleth wave, that means that it's incorrect. And the sat that you're getting is wrong. Okay? You can confirm pulses in ROSC. You get a patient back. You hook up a pulse ox. I'm not saying put it on during CPR, but if you have time or it's already on, it's something that you can observe quantitatively. Any premature contractions are actually perfusing. Are the PVCs or PACs that we see actually contributing to blood pressure? That's something that you can determine. You can print it and show it. Look, doc, the PVCs are actually contracting. I have a waveform with each PVC. Pulsus paradoxus talks about fluid around the heart. Patient inspires and all of a sudden you have no pulses. And then it comes back when they exhale. Changes in pressure inside the heart. So you can determine that and show that it exists. Sinus arrhythmias, or again, based on respirations. High quality CPR. Again, I'm not telling you go ahead and put a pulse ox on every cardiac arrest